As you watch this program, some women and infants have just died in some parts of Nigeria. And at the end of today, more than 2,000 children under the age of 5, as well as more than 100 women will have died. This is the sorry state of infant and maternal health in Nigeria. This is Health Business, and my name is Oluwatoyin Kolawole. On the program this morning, we shall be taking a look at infant and maternal health in Nigeria, particularly maternal mortality rates. But first, let's bring you up to speed with the happenings in the general health scene across the nation.
In a bid to bring succor to indigent people with spinal and orthopedic issues in Lagos, the management of Lagos State University Teaching Hospital, LASUT, in collaboration with Lokmaya Hospital in India, recently put together a free medical care for orthopedic patients with joint replacement and spinal cord injuries. While addressing health journalists at the event, LASUT's Chief Medical Director, Professor David Oke, justified reasons for the program. He said the high number of indigent people with orthopedic and spinal cord injuries in the country was a thing of worry, hence the free care.
Nigerian patients are going to benefit from orthopedic surgery, spine, hip, and joint surgery, and they're going to get it virtually free. This exercise will take 2 days. 2 days. Today, tomorrow. And once it's concluded, we would have the opportunity in not so much a future to have this repeated.
LASUT Director of Clinical Services, Ayo Adedokun, noted that the free medical camp will also serve as an exchange training for their medical doctors and will also reduce medical tourism.
It's the very first camp to screen our patients, to see them and try and do some skills transfer to our local professionals, do what we call cross-fertilization. And the end result of that is that medical tourism will eventually reduce significantly.
Leader of the team from Lokmaya Specialist Hospital India, Krishan Mohan Sharman, promised that the free orthopedic and spinal cord treatment will not be a one-off.
I just want to give all specialized service and to have the collaboration between LASUT so that the skills of the doctors are enhanced, and moreover all this super specialty work whatever our doctors are doing, it can be further developed over a period of time. So with this, thanks for our CMD and CMA to give us this wonderful opportunity to explore and do the exchange program and to help the patient of entire Nigeria.
Many patients with orthopedic issues thronged the venue of the free services, while many were attended to by the foreign specialists.
Every single day, Nigeria loses about 2,300 under 5-year-olds and 145 women of childbearing age. This makes the country the second largest contributor to under 5 and maternal mortality rate in the world. Underneath the statistics lies the pain of human tragedy of thousands of families who lost their children. According to research by the World Health Organization, if essential interventions get to women and babies on time, it will avert most of these deaths. Joining me on the program this morning is the Professor of Obstetrics and Gynecology, Professor Oluwarotimi Akinola, and is also the second president. You welcome on Health Business. So for the benefit of our viewers, I want you to define what maternal mortality is all about.
Maternal mortality is the death of a woman in pregnancy and within the first 42 days after delivery, regardless of the mode of delivery. So basically speaking, it is the death of a woman during pregnancy and within the first 42 days. That's the universally accepted definition right now.
So why is Nigeria the second largest country of maternal mortality ratio in the world?
Well, because we've left undone a lot of things that we ought to have done. There are countries that had very poor statistics like we did, like Malaysia, Sri Lanka and all those places, and they've had a very substantive improvement in the status. So basically speaking, there are laid down procedures that if you adopt them, you are likely going to impact on this. Of course, where there is poverty, where socioeconomic status is low, maternal mortality is usually high. So there's an inverse proportionality between the two. So perhaps that's one of the reasons why it's still high in Nigeria.
In your own view, will you say poverty is a contributing factor to maternal mortality ratio in Nigeria?
It is a major contributory factor in several ways. I would not just say poverty alone. I would say low socio-economic status, because that also includes your educational status and all that. What we know is that an empowered woman is less likely to die from pregnancy-related causes than somebody who is not. And so for somebody, for example, we talk about some delay model. And the delay models we talk about, for example, is we say that if the person is not seeking help, it's somebody who is pregnant that does not know that he should attend antenatal services, that does not know that it's safer to have delivery attended by skilled attendants, certainly the likelihood of a mishap happening is higher. Now, why I say socioeconomic status, of course, it has to do with access and all that. So if you cannot access it because you do not have money, perhaps because it's expensive or something, again, you run into a problem with that. So there is no, you must have heard, basically we have a birth rate that is very, very high in Nigeria. And the truth actually is that, again, a direct proportionality between poverty and high birth rate, and of course also with maternal mortality. So that's the kind of thing that obtains.
What is the place of family planning in curbing maternal mortality?
It's very major. The first thing actually is that if you do not get pregnant, and that's an area of reproductive health. If you don't get pregnant, you are not likely to die from pregnancy-related causes. And there are quite a lot of, there is something they call the unmet need. There are quite in Nigeria today, the contraceptive prevalence rate is probably just about 16%. So the implication of that actually is that there are people who will get pregnant not because they want to get pregnant. And if they get pregnant, they probably resort to one of several things. They get on what we call the maternal mortality road once they get pregnant. So the first bus stop will probably be the one to abort. And if they have an unsafe abortion, you know, abortion laws in Nigeria are restrictive and all that. And so if they get unsafe abortion, I don't want to say illegal abortion now, the likelihood that they can die there and then is there. They can bleed to death, they can get infected and all that. You know, we're already talking about maternal mortality from abortion. Now, if they don't die and they survive, then all the other problems that could come along from hemorrhage, bleeding at delivery, infection, hypertensive complications and all that sort of thing, then will stem in. So if you don't get pregnant, you are not likely So if there is good family planning, you can reduce. In fact, there are modems that had shown a reduction of as much as 38% or so with increase in family planning. That if you increase family planning uptake, then you are likely to reduce maternal mortality.
So what can the government do to reduce this burden of maternal mortality in Nigeria?
First and foremost, the government is responsible for a lot of things. Improvement in socioeconomic status, like I said, because we have to go out there. We also have to make sure, for example, that by advocacy, by everything, that people should know that they need to take care of themselves. They should be educated and all that. If, for example, you reduce, you promote family planning. 2, if you reduce child marriage, it's a fantastic thing, because the truth actually is that the younger a person is who gets pregnant, the more likely is going to indulge in also dangerous things like a teenage pregnancy, leading to miscarriages, leading to abortion and all that sort of thing. So everything we're talking about still fits in there. And so you find out that if you can, from that perspective, weave it on, the government can do that. Government provides the facilities, the personnel. If you make sure, for example, that access, because the second delay is in saying, for example, accessing care where you need it. If there's no road, if there's no transportation, if you don't have the centers to go to, and they are far, if you have to travel kilometers before you can get to a health center. So if we follow what the Alma Ata declaration was, make primary health care system very effective and available, then you find out that it reduces the burden that's going up there. So you tackle a lot of them there and you prevent a lot. So government indeed has a big role to play, a commitment.
Lastly, when President Trump came to power, he reintroduced the global gag rule. And I'm just thinking, in your own view as a gynecologist, what do you think will be the effect of this rule to the Nigerian women and girls?
Of course, it's going to be deleterious. We've been talking about the fact that it is good for us to own our programs. In a situation where, for example, you talk about HIV and all those things, and you find out that the bulk of the funding is coming from NGOs and from foreign bodies and all, there is going to be, so there should be ownership of our program. So if we're talking about of family planning services, it shouldn't just be left to NGOs and foreign donors bringing it in, so that the government itself is involved. I'm aware that that's being done. It's been scaled up gradually. So by and large, you cannot, you want to shut down polio. You know, for example, that without commitment, government commitment and all that sort of thing, you're not going to succeed, because the truth really actually is that if you're just depending on donors, once they switch off other priorities come up and they switch off the funds, then you are back to square zero. So that's been one of the major problems with Nigeria, that lack of government, so it's lack of government commitment to resolving some of those issues.
Well, it has been so nice having you on Health Business this morning. Thank you so very much, sir.
Hello viewers, I'm Dr. David Ikudaisi, a board-certified internal medicine specialist in US, and I'm also a regenerative medicine specialist. I'm here to educate you on regenerative medicine. For those who are not familiar with the term regenerative medicine, it's a new branch of medicine that aims to restore normal functioning of the tissues and cells and tissues in the body, of the area of that body that has been damaged either by disease, age, or due to congenital conditions. Now, regenerative medicine comprises platelet-rich plasma therapy and stem cell therapy. The stem cell therapy can also be divided into 3 areas, which is embryonic stem cell therapy, induced pluripotent stem cell therapy, and adult stem cell therapy. The first 2 that I mentioned, They are still in research stages because of the possible side effects that they may pose to human beings. But the third one, adult stem cell therapy, is gaining popularity due to the fact that it has been proven to be safe, although there's still a lot of studies and research going on. But today, it's still possible to use adult stem cell therapy to address some conditions or issues that the orthodox medicine have already said there is no further cure or treatment available. Now, I would like to also explain what platelet-rich plasma is, because some people may not be familiar with what this is. Platelet-rich plasma is when you use a patient's blood to treat the patient by first of all concentrating the blood and separating into plasma and red blood cells. There's a section after centrifuging the blood that is very rich in platelets. That is where the name platelet-rich plasma comes from, and can also be referred to as PRP, therapy. And what you get is that in that sample of blood, the platelets are being concentrated about 5 to 10 times more than the baseline, and that allows the area where you need it, to get the benefit of high concentration of platelets. As far as stem cell therapy is concerned, a stem cell is any cell that can self-replicate itself or differentiate into any matured cell. Now, there's been a lot of controversy about stem cell therapy. Keep in mind, this is just when people are talking about embryonic stem cells. And the reason of the religious or ethical controversy is because embryonic stem cell therapy involves using, let me say, embryons, which sometimes they are being donated by the IVF clinics, because these are all potential human beings. Therefore, there's a lot of religious reasons, controversy about that. The second type that I mentioned earlier, the iPSC, which is induced pluripotent stem cell therapy, is like when you take someone's skin to the lab, reprogram it, and make it maybe grow the nose, hair, or some tissue organ from it. That has similar characteristics like the embryonic stem cells, but they do not have any religious controversy, because you are not dealing with potential human being here, And then the third type of stem cell therapy that I mentioned earlier is called adult stem cell therapy. The word adult is not about age, but it is just referring to the fact that the source of that stem cell is from fully formed human. So that because adult stem therapy covers umbilical cord blood, bone marrow transplant sometimes is considered under regenerative medicine, and also fat from the abdomen can be a source of the stem cells. So to make it a little bit clearer, there are 3 sources of adult stem cell therapy, which is the only type of the 3 stem cell therapy that today currently have clinical applications. And those 3 sources are umbilical cord blood, bone marrow, and fat. So those are the 3 sources. I hope I've been able to break down or explain what regenerative medicine is all about. Next week we will continue by discussing what are the ailments, conditions that regenerative medicine can address. I'm Dr. David Ikuda-Isi, regenerative medicine specialist. Thank you.
Next on the lineup is the pharmacy segment. Stay tuned.
The pharmacy profession has expanded significantly around the world in terms of professional service delivery, especially in the last 2 decades. It has been recognized as an important profession in the multidisciplinary provision of healthcare because of its current evolution towards clinical orientation, otherwise called pharmaceutical care. Community pharmacy is a branch of this great profession, and by the job description, the most accessible healthcare providers to the public because of the proximity of the pharmacies to the community residents. In an interview with Health Business, the national chairman of Community Pharmacists in Nigeria, Albert Alkali, revealed that community pharmacists are underutilized resource in the healthcare delivery chain in Nigeria.
If you have the community pharmacists doing very well, it's the community pharmacists that actually graduate in most cases to manufacturing. So once we have that interaction, once we have that enabling environment, I want to assure you, in the next shortest possible time, within 5 years or so, we should be able to produce close to 60 to 70% of our requirements in this country. It's the enabling environment we want government to take care of.
Alkali noted that community pharmacy in the country have a significant role to play in the effective provision of qualitative healthcare delivery in Nigeria. But the environment they operate in falls below acceptable standards.
We've talked to the federal government to create an enabling environment for the production to be done locally. Now, they can do that by ensuring that there's stability in power supply, by providing the necessary infrastructures for pharmacists to be able to set up a manufacturing outfit to be able to produce most of these antiretroviral drugs locally, and also by ensuring that community pharmacists have access to facilities at one-digit interest rate.
Alkali, however, pointed out that drug misuse in Nigeria has frequently been described as irrational, and the communities are worst hit by it, since dispersing of drugs has been hijacked by non-professionals who have no business in handling medicines.
We need the system to be sanitized. All these tools will contribute into the encouraging local production and ensuring that we're able to meet the local production of antiretrovirals for HIV/AIDS patients, and also the anti-cancer drugs for cancer patients.
The community pharmacists have a responsibility to alter this misconception by offering value-added services that carry professional touch in the day-to-day running of their pharmacies, because they are the closest and also occupy a vital position in the hierarchy of healthcare providers to the public.
It's now time to join Dr. Abayomi Ajayi on Understanding Infertility.
Welcome to Understanding Infertility. My name is Dr. Abayomi Ajayi, and today we're going to try to discuss something very, very interesting. I'm sure you know it's no longer news that we can have babies from IVF. Over 6 million babies have been gotten from this process all over the world. But what everybody is now focusing on is that we want to have healthy babies from IVF. When I say healthy, what I mean is that babies that are free from genetic diseases that even their parents are carrying. And that is what we're going to be discussing today. PGD, PGS, pre-implantation genetic diagnosis and pre-implantation genetic screening. Now, there's a small difference between them. As we go along, you'll be able to understand what I'm talking about. The thing is that about birth defects are commoner than we imagined. About 1 in 20 pregnancies, we have birth defects. But some couples, you will agree with me, are more risk than the other, especially those when the two of them are what we call carriers. The test that we can do in order for us to be able to look at applying genetics, that's what I mean, to IVF. That there's so many tests that we can now do in order to prevent this transmission of genetic diseases. So I'm going to take them stepwise. The tests that we can do before conception, the tests that we can do, conception is pregnancy, you know that by now. The tests that we can do even when the woman is already pregnant, and then, of course, the tests that we can do during IVF treatment, and the tests that we can do to understand, for example, if there's been a pregnancy loss. Why did we lose this pregnancy? You know, because many people don't know that, especially in the first 3 months of pregnancy, about 50 to 60% of such embryos are not normal, whether it's from IVF, whether it was done naturally. Now, the other thing to ask me is, why do we need to do this test? Why do we need to look for genetic disorders? The first thing is, when the woman is above 37, we've known that the incidence of genetic disorders increase in a woman above 37. In some other countries, when you are pregnant above that age, the heavens are going to be let loose until they are able to prove that the baby you are carrying is free of genetic disorders. We're not yet there in this country, but we're moving towards it. And I'm sure we'll soon get there, when you have such facilities that we can detect so many congenital abnormalities or many birth defects. They say ignorance is bliss, and many people I hear so many people telling us that congenital abnormalities are not common in this environment. That's not true. The truth is that we're not picking them up enough. The other indication will be for a family that has the history of genetic disorders. For example, the easiest one that I can tell you, like we said, is sickle cell disease. But there are other things. Some people in their family, they carry the gene that causes blindness. In some people, they carry the gene that carries deafness. In some people, it's color blindness, just color blindness. You know, in people who have had recurrent miscarriages, you know, then also there are people that we should start screening them for genetic disorders. You remember I told you that the first 50 to 60% of babies in the first trimester, the first 3 months, that the reason why they're lost is because of congenital problems, because they're genetic problems. Then in men who have very poor sperm counts, what we call severe oligospermia, and sometimes even mesospermia, you know, when we have to go and check sperm for somewhere else, it's good enough for us if we can also do genetic testing. And for some people, it's just because they want a particular gender, what we call gender balancing. They've had this number of maybe boys or girls, and they want to have this number. They want the other gender. So it's also for gender balancing, and for people who have had what we call recurrent IVF failure. These are people that will benefit from this test that we're talking about. Remember, together we can conquer infertility. My name is still Dr. Bayomi Ajayi. Cheers.
This is where we draw the curtains on today's episode of the program. You can be part of this program by calling the numbers showing on your screen. My name is Oluwatoyin Kolawole, and the program is Health Business. Remember, living healthy is a serious business. Bye for now.
Thank you.